stone disease. It can identify stones located in kidney like renal calyx, pelvis, upper ureter, and vesico-ureteric junction. But in middle part of the ureter, which is obscured by bowel gas and pelvic bone, it cannot identify a ureteric stone. And many a time we see in a report mild to moderate hydronephrosis, but stone cannot be seen. Then second investigation, which was very common in past, was X-ray KUB. The advantage and disadvantage is it is a very fast investigation. We can do it whenever we want in a single shot. But the problem is it requires mic बंद हुआ. Specific preparation, like patient has to be empty stomach. It has to be done in morning. Proper bowel preparation, otherwise excessive bowel gas can affect the sensitivity and specificity of the X-ray QB. But if you are nowadays, we are performing non-contrast CT scan abdomen as a primary investigation for the stone disease. If we are planning to do that, X-ray QB is not indicated. Now, the most important debate which we even in the urology forum do is which is good, non-contrast CT scan or old gold standard intravenous urography. So first I'll say in the past IV was the gold standard investigation for diagnosis of the kidney and ureteric stone. But with now the non-contrast CT scan abdomen is the investigation which we should do in a patient who come with a ureteric colic in our emergency or in our OPD. The advantage of non-contrast CT scan is there is no need to giving intravenous contrast, which is nephrotoxic as well as allergic. It is a single shot investigation with high spiral scan, CT scan. It can be done within 5 minutes. It has a very high sensitivity and specificity, almost 95 to 100%. All stones more than 2 millimeter can be diagnosed. And most important thing, if the patient comes with the acute colic, at that time, temporarily the dead kidney goes into shutdown because of vasospasm and prostaglandin release. And if we do IV at the time of acute colic, there will be no nephrogram, no contrast secretion of kidney. It will just give anxiety to the physician if he doesn't know about that, and anxiety to the patient, which may be reported there is no excretion of contrast in the kidney. So acute colic, never perform contrast CT scan or IVU. Then comes investigation. You can do lots of investigation, but there are some specific investigation and its interpretation in the stone diseases. First is urine investigation. pH, as I told, normal urine pH is around 6.5. Most of the stones, calcium oxalate stone, which is the commonest, is present in this pH. If you have a stone with pH of less than 5.5, that is the acidic urine, we should suspect it to be have a uric acid stone, because at this low pH, the uric acids become crystalled and the form very easily can form a stone. Even low level of uric acid in the urine or blood at that low pH of 5.5 or less can produce a uric acid stones. Same, if pH is more than 7.5, we generally see this in a urea splitting organism, urine infection, and commonly associated with stew white or infective stones. Then presence of RBCs. Most of the time, stone disease will be presented with RBCs because of the movement of stone and some irritation or damage to the urological mucosa. So we should not give much importance if there is a presence of stone with the RBCs in you. Same thing is with WBC. We have to understand WBC pus cells are not always indicative of infection. It is a cells produced by our own bodies in response to any injury or damage to our urinary tract, whether it is because of infection, foreign body stones. So in absence of any symptoms suggestive of infection, presence of pus cells or WBC cells in urine routine examination does not warrant starting of antibiotic in a stone disease, because most of the stones are non-infective. Unless and until there is a clinical symptoms or other features or blood investigation suggestive of infection, antibiotics should not be given in the management of stone disease. In blood investigation, CBC is done before the infection. Renal, sodium, potassium are done the part to know the etiology of disease. Like some diseases I will discuss later on are associated with the change in the sodium and potassium and chloride level of the blood. Serum calcium, as all you know, calcium is one of the common of stone. So if it is high, then we have to evaluate further what is the cause of hypercalcemia and first manage that before going for the stone disease management. Serum uric acid, same. If serum uric acid is more, it can lead to formation of calcium oxalate stone or uric acid stone, which we'll discuss later on. So now we'll come to the management. So for the ureteric stone, any stone less than 10 millimeter or even bigger stone can be treated with medical expulsive treatment, which is a conservative treatment for ureteric stones. In this, the treatment includes good oral intake of fluid. There is no requirement of IV fluid or overhydration of the patient. Just improve the oral intake of fluid. Give smooth muscle relaxation, which have been widely studied and the data have come is a tamsulosin. If we use this smooth muscle relaxation, which are present in lower and middle part of the ureter, it reduces the requirement of analgesics and improves the pain-free duration of a patient. So patients can better tolerate the medical expulsive treatment and are able to complete their medical expulsive treatment duration. Other smooth muscle relaxation like calcium channel blocker, PD5 inhibitor like tadalafil have also been studied but not widely, and we don't recommend them at present because tamsulosin has a very good result, especially in the mid and lower ureter because of presence of alpha receptors in the smooth muscles of lower and mid ureter. Analgesics is SOS if patient has a pain. Steroids also some people may recommend. Now the combinations have come, it reduces inflammation, edema, but steroid has its own side effects. So generally it should be avoided in ureteric stone disease in a combination of alpha blockers. Now some products have come, a combination of alpha blocker with steroid for ureteric stone, but generally it should be avoided. Contraindication for medical expulsive treatment is if patient has a clinical and blood reports are showing infection. One thing more, sometimes because of ureteric colic, the WBC count may increase to 13-14,000 or something borderline high, but without any infection. So we have to see whether patient clinically, because most of the time if there is a ureteric stone and infection, patient will present with fever, chills and weakness or lethargic because it's an obstructed system with infection. So just borderline raised WBC count may be non-infective just because of ureteric colic trauma to the body. So if there is a clinically and investigation shows infection, if there is a solitary kidney or bilateral ureteric stone, as I told during ureteric colic, that kidney goes into shutdown and patient may present with acute renal failure if he goes into acute ureteric colic with solitary kidney or bilateral stones. Patient has a severe pain which is not responding to conservative treatment and requirement of analgesic is very frequent and requirement of injectable analgesic is very frequent. Our patient is not willing for follow-up or not will not be able to come for follow-up, like patients working in a ship, flight or some other job, army, where they cannot take leave for more than 3 months, 6 months, 1 year, they cannot come for follow-up. These patients should not be kept for medical expulsive treatment. So now we go for the management of kidney stones disease, and this is whole worldwide accepted plan depending upon the size and location of the stones. So if it is more than 2 centimeter, 20 millimeter stone, still the PCNL is gold standard. Now with newer ureteroscopes and uh, high watt lasers, some stones in patients where PCNL is contraindicated or is very difficult, we can do still go ahead with RRS, but still more than 2 centimeter stone, PCNL is the treatment of choice. Some people we may give ESWL, but now ESWL is absolute. I will discuss later on what are the reason for that. 10 to 20 stones, RARS is the investigation, that is flexible ureteroscopy with intracorporeal breaking of stone with the laser. PCNL is the second choice. ESWL is the third choice. Less than 10 RARS or ESWL can be given, or if in some indicated stone with anatomical unreachable areas, PCNL can be performed. Lower calyx stone, generally it has an acute angle with the pelvis. So some difficult cases we may have to perform PCNL, or if it is favorable anatomy of the lower calyx, we can do RARS. ESWL is generally not done in lower calyx stone because of the gravity. The stones, even fragmented, will not come out from the lower calyx and will not come out of the kidney. Sorry, just acute colic, like this slide came later. So acute colic, I will tell that acute colic, the reason is prostaglandin released from the kidney during to complete obstruction of the ureter. So best drug if the renal function is normal is a non-steroidal anti-inflammatory drug. Though people feel it is a nephrotoxic drug, but severe acute colic will respond to diclofenac or brufen only. We can give few doses of that. If patient has a renal insufficiency, then only we should go for opioids like tramadol or other opioid drugs. Antispasmodic in acute uritic colic is not very clear role. Generally, antispasmodic like hyoscine or buscopan or dotaverine is used in a patient who have a chronic pain because of stretching of renal capsule and ureter. That is for the smooth muscle relaxation of the renal capsule and ureter. So for severe acute uritic colic, which is, I can say it is one of the severe pain a patient will feel in his life. It is almost like fracture of bone or like pregnancy pain. Best is if renal function is good to be treated with a non-steroidal anti-inflammatory drug, diclofenac or brufen. Often we see a patient presenting with nausea along with the acute colic. This is because of sympathetic stimulation associated with colic, and it causes reflexly pyloric spasm and patient develop reverse peristalsis and projectile vomiting. So if we are able to control the colic pain, automatically the nausea and vomiting episodes will reduce. So now we'll go for the treatment of kidney stones, ESWL. The advantage is it has required no anesthesia, no intervention. It can be given on a daycare OPD basis, discharge on the same day. But the problem, now we'll just discuss the history of ESWL. It started before PCNL and everything in late 70s and 80s when the treatment was open surgeries only, like pyelolithotomy, nephrolithotomy or anatopic nephrolithotomy, which are very major surgeries for small size stones and associated with significant morbidity to the patient, even loss of kidney at the time of surgery or in the post surgery period or sometime with the mortality. So these treatment become very like favorable for the smaller stones less than 1.52 centimeter stone. Just break the stone and allow the fragments to come out. But it has a significantly less success rate as compared to now recent treatments like PCNL or RARS, which came significant period after ESWL. So poor outcome we see in patient with harder stone like Hounsfield unit more than 1200, lower calaxial stones associated because of the gravity does not allow the fragments to come out. Hydronephrosis. When there is a hydronephrosis, it's very difficult to localize stone and vibrate it with the shock wave because stone will start moving in the hydronephrotic kidney and it will not be able to break the stone. Renal anatomical anomalies like PUJ obstruction, horseshoe kidney, pelvic ectopic kidneys, multiple stones, or distal obstruction like uretic associated with uretic stone or uretic stricture. Contraindication of ESWL in pregnancy due to potential effect on the fetus if patient has a bleeding diathesis, because ESWL causes significant renal and perirenal hematoma and hemorrhage, uncontrolled urinary tract infection, severe skeletal malformation or obesity which does not allow the shockwave to reach to the stone, like spine deformities or very obese BMI more than 35, 36, where the skin to stone distance is so much that the waves can, the point of the wave where it has to break the stone will not reach to the stone. Nearby arterial aneurysm and atherosclerotic arteries on CT scan or investigation because it can break or rupture this aneurysm. Anatomical obstruction distal to the stone. Complication are renal perirenal hematoma, hematuria, sepsis, ureteric colic because of multiple fragments. Sometimes bigger fragments can pass through the ureter and cause Steenstrasse, that is a multiple chain of stones fragments accumulated in the lower mid ureter. PCNL. Now, there was a time when it was gold standard for kidney stone disease. Still now, for more than 1.5 centimeter, it is the treatment of choice. It has almost completely replaced pyelolithotomy and nephrolithotomy. Now, most of the urologists which are trained in the newer days will have not done or seen any pyelolithotomies or nephrolithotomies in their teaching or training. Success is 95 to 100%. Good for harder stones because the energy used can directly stone even harder stone like cystine or calcium oxalate monohydrate stone, which has a Hounsfield unit of 1500. Lower calaxial stone we can directly puncture in the stone bearing calyx and remove the fragment, so there is no dependency or related drainage problem. And calaxial diverticular stone, which anatomically is not possible to reach by flexible ureteroscopy, can be managed with PCNL. So when it started, it was also deadly surgery. started with 34 to 36 French sheet size was used when it started in 80s. And it used to say that one PCNL used to cause 5 to 6 grams of hemoglobin drop. Whole theater and blood the used to be soaked with the blood with and initially the puncture and kidney access was done by the radiologist and the procedure was done by the urologist. Slowly the procedure has become more standardized. The sheath size which we used to introduce nephroscope and break stone have reduced. Now generally we use 24-26 French sheath which is around 1 centimeter in size. With the advent of the laser, the smaller scopes have come like mini perk where we use less than 22 French sheaths, which is 20 French and 16 French sheaths. Ultra mini perk, which is 11 French and 13 French sheaths. Mini micro perk, which uses 8 to 10 French, and micro perk, which uses almost like needle, 4.85 French sheath. Sorry, I just do fast. So why small tract? As I told, bleeding is more serious complication. So if you reduce the tract size, it reduces the chances of bleeding complication, which is one of the deadliest complication of PCNL. These are the papers which have shown that mini perk is associated with red blood cells. So these are the advantage. So micro perk, as I told, it uses a needle with the all attachments to break the small stones in the pediatric patients, especially. So contraindication of PCNL is generally uncorrected coagulopathy, pregnancy, and infection because it cannot be done in a without C-arm. So pregnancy, you can't expose the fetus to the radiation. Complications like common complication is bleeding. If upper calyceal stone sometimes can lead to pleural injury, pleural effusion, infection if there is an uncorrected infection, and sometimes liver, spleen, or colonic injury, which may be anatomically little bit variation and can come in our tract. RRS now it is the very commonly used procedure for the smaller stones less than 1.5 centimeter stone, which uses natural tract. No puncture to the kidney, skin is required. We can directly see the stone and break it with the laser. So harder stones can be fragmented, broken with that. And if there are multiple small stones in the people who like working in an airplane, ship crew members, which requires complete clearance, even small fragment cannot be left in them, are very much helped by this procedure. There is advancement in this RRS. Initially, it was fiber optic scope. Now we get a digital video ureteroscope with a very good vision and significantly reduced cost. So overall availability of this procedure is quite commonly available in most of the centers. Complication of RRS is infection sepsis because it's a closed system we use to irrigate the fluid. So if there is untreated infection, diabetic patient, old patient, immunosuppressed patient can go into the sepsis. And staging of procedure because we use normal tract, sometimes tight ureter in almost 10% of the people, we may not be able to perform primarily and we may have to stage the procedure with degestanting. Ureteric stones. For the lower ureteric stone, gold standard is ureteroscopy. There is no replacement. It is just, you have to go with ureteroscopy for the any stone below the SI joint. Upper ureteric stone is little bit tricky because of the tightness of ureter, the angulation of psoas muscle. It requires a smaller scope laser to break the stone because otherwise the stone may migrate into the kidney, which may require any other procedure if you have a flexible ureteroscopy or PCNL. Complication of ureteroscopy, URS are infection, ureteric injury or ureteric avulsion. That can be considered as a devastating complication that should be avoided. Ureteric stricture is seen in like 4 to 5% of the patients over the longer term. So most important, once you have treated stone, but most important in India because it's so common is to prevent the recurrence of stone disease in the patient who comes primarily or comes with a recurrent stone disease. Universal precaution are advise patient to drink plenty of fluids, but plenty of fluids, I have seen many patients, plenty of fluid for them means 4, 5, 6 liters, 8 liters also people drink. So aim should be to maintain urine output around 1.5 to 2 liter per day. Tell them to drink at equal interval every hourly 1 glass of water till they are awake is the best way of treating it. It doesn't matter whether they are drinking RO pure water or normal water or tap water. Any water will be useful. Now RO water, so it's coming with lots of side effects. So there is no role of RO water. Less sodium salt, as Hase sir told. Salt, because of increased salt, sodium excretion into the kidney, and in response to that, the tubules start excreting calcium into our urinary tract. And if there is a more sodium in your blood diet, it will increase the calcium excretion into the kidney and increase the chances of calcium stone. So try to reduce universally all patient of calcium stone disease the salt intake. Less animal protein because it causes renal acidosis and hypocytaturia, which is inhibitor of stone to increase the chances of stone formation. 20 so most important investigation in prevention of stone disease is 24-hour metabolic evaluation, urinary metabolic evaluation, which should be done in a patient who have a recurrent stone, younger patients, multiple bilateral stones, single kidney stone, anatomical abnormalities like horseshoe kidney, PUJ obstruction, or patient who does not want recurrent stone, like because of their job, like working on a flights, sea crew or army or air force people. So we should do 24-hour metabolic study, which is include calcium, oxalate, uric acid. These are stone precipitator. If they are high, they increase chances of stone. Citrate, magnesium are stone inhibitor, and creatinine generally we do to normal understand that our urine sampling is adequate. If 24-hour urinary creatinine is less, that means that patient has not given adequate sample and one or two samples are missed. So hypercalciuria, it may be because of hypercalcemia. So we have to evaluate serum PTH, malignancies or other causes. First correct this. But other causes of hypercalciuria are dietary, which is not very common, but if it is associated with normal or borderline high serum calcium level, these only patients, very few patients of hypercalciuria or calcium stone disease are benefited by dietary restriction of calcium. Otherwise, most of the patient, if we try to restrict calcium, will increase chances of stone disease, which I will tell later. And commonest cause of hypercalciuria is renal leak. As I told, the renal tubules leak calcium into the urinary system. These patients should be treated with thiazide diuretic, which has the same role as reducing the sodium excretion and into the tubules, and then reduce the calcium excretion into the renal tubule, which should be along with that, we should give potassium citrate to manage the hypokalemia associated with thiazide. Hyperoxaluria type 1 is genetic case which has a very high oxalate level, has to be treated with combined liver and kidney transplant. Type 2 mild hyperoxaluria should be treated with pyridoxine, vitamin B6 and high calcium diet, because calcium chelates with oxalate in our intestine and reduces its absorption. Same thing in with secondary, we have to increase the calcium diet of the patient to reduce the absorption. Hyperuricosuriya, generally hyperuricosuriya can be manifest as both calcium oxalation. If the urine pH is more than 5.56, generally they are in diluted state, but they increase the precipitation of calcium oxalate crystals and stone formation. So if there is a hyperuricosuriya calcium stone, this patient should be aimed to reduce the serum uric acid level by allopurinol or febuxostat and reduce dietary intake by reducing animal protein. If pH of urine is less than 5.5, mostly these are uric acid stones. The main treatment of this uric acid stone, this is the only stone which dissolves with the medical treatment, should be treated with alkalinization of urine with like potassium citrate or sodium citrate, or what we give cetal syrup, whatever we want to alkalinize, or sodium bicarbonate to alkalinize the urine, make the pH more than 6.57 and increase urine output of more than 2.5 liter per day. Hypocytaturia, generally we see, which is a stone inhibitor, we see in patient with metabolic acidosis, renal tubular acidosis, diabetes mellitus, patient on high animal protein diet, especially red meats, obesity with metabolic syndrome. These all in one or two ways reduce to renal tubular acidosis and reduce the citrate excretion into the kidney. So treatment of reduce all these causes, prevent these and add potassium citrate. So mainly these patients with hypocytaturia or renal are benefited by potassium citrate. So potassium citrate should not be given to all patients. Thank you.
Body. And it is no exaggeration to say that the composition of the blood is determined not by what the mouth takes in, but by what the kidney keeps. So prevalence of kidney disease is increasing. 850 million people are affected by the kidney disease. Chronic kidney disease is a major non-communicable kidney disease that affects 1 in 10 people worldwide. And the prevalence is 10.4% among men and 11% among women. And in India, the prevalence in the Indian registries are found between 12 to 18%. And diabetes is the most common cause of chronic kidney disease now in India. And India is becoming a capital of diabetes. So the burden of kidney disease is definitely going to increase. And the patient going with the kidney disease for surgery is going to increase. So patients with kidney disease go to undergo various surgeries like kidney transplant, urology surgery, fistulas, kidney biopsies. But non-nephrology surgeries are also required for these patients like the cardiac surgeries, orthopedic surgeries, abdominal surgeries, neurosurgeries, and minor surgery like dental or cataract. So if the patients can undergo transplants and urology surgery, definitely they will be able to undergo other surgeries also. So why this surgery is a high risk? The perioperative management is complex and challenging because patients are having azotemia, uremia, hyperkalemia, metabolic acidosis, bleeding due to uremia, tendencies are increased, altered duct clearances in kidney diseases, and associated comorbidities like diabetes, hypertension, and ischemic heart disease increases the further complexity and risks. So outcomes of surgery seen worldwide are once the creatinine is twice the normal value, the mortality is increases by 4 times. Also, in cardiac surgeries, the patients with CKD had 1% mortality translated to 12 to 15% mortality with kidney diseases. Also, patients undergoing non-CKD patients undergoing open vascular surgery had 5% mortality, whereas those with CKD had 16% mortality. Similarly, 1% with non-CKD had 10% mortality in the endovascular surgeries. And in Veterans Affairs studies, the CABG surgeries, doubling of creatinine had doubled the mortality risks. So why mortality is high? It is because of the cardiovascular complications associated, perioperative complex fluid and electrolyte disturbances, particularly hyperkalemia, surgical bleeding complications, poor perioperative blood pressure control, hypertension, hypotension is happening, and increased requirement of vasopressors and supporting agents. So what is the answer? So answer is perfect perioperative evaluation for perfect perioperative outcome. So careful history should be undertaken to assess the patients, to assess the kidney disease of the patient. So first is to find the underlying cause. So we have to determine whether patient has an acute kidney injury, whether his creatinine was normal and now it is increased kidney function is deranged, or whether patient is already a kidney disease not on the dialysis, and what is his baseline kidney function, and whether he will require dialysis as a preparation for this surgery. If patient is already on dialysis, a kidney disease patient, how to optimize him on the dialysis, and whether patient is an acute on CKD, wherein patient already has CKD and is acute worsening. Also, to find out the CKD related complications, whether patient has anemia, hyperkalemia, hyponatremia, whether patient has metabolic acidosis, all these complications has to be identified. Associated comorbidities, diabetes, IHD, and lower urinary tract symptoms are very important to inquire whether patient has an active urinary tract infection, whether patient has lower urinary tract symptoms, to know whether patient will undergo catheterization, or whether post-operatively whether he can have complication like urinary retention. So careful physical examination to assess the volume status, which is very important. We need to assess the volume status, whether patient is hypovolumic, we need to optimize this volume status. Whether patient is hypervolumic, we need to add diuretics to optimize the patient. Nutritional status, we know that poor nutritional status has a poor surgical outcomes, and blood pressure control is very important. Lab evaluation, CBC, to know the hemoglobin, we need to optimize the hemoglobin to know whether patient is an active infection, platelets, urine routine to know whether there is active urinary infection, or patient is asymptomatic bacteriuria. Asymptomatic bacteriuria may not warrant treatment unless patient is undergoing catheterization. Electrolytes, then calcium, phosphorus, which may get altered in acute kidney injury and chronic kidney disease. Most important coagulation parameters like PT, PTT, INR, and thromboelastogram in high-risk patient. And also ECG and 2D echo to know the basic baseline cardiac status, and also as a tool for volume assessment with 2D echo to know the IVC, to know the heart pressures, lung comets. They can guide us as for a fluid assessment. So how do we optimize this patient? So volume status. So as we discussed, if patient is hypovolemic, we give IV fluids and optimize the volume status. We don't want patient to be dehydrated before patient goes into surgery, which can again propagate the acute kidney injury. If the patient is hypervolemic, has excess fluid, we need to add diuretics and get the fluids down. And if patient is euvolemic, we still need to maintain them on the maintenance fluid. Serum potassium should be less than 5. It has a bimodal peak. If potassium is less than 3, again, it is not good for the cardiac. It will cause chronotropic effect. If potassium is more than 5, it will cause bradycardias and arrhythmias. Serum sodium needs to be more than 130 because post-surgically, if patient has pain, there will be non-osmotic secretion of ADH, and which will cause free water retention and further worsen the hyponatremia. And we have got calls for the seizures post-operatively because of the low sodium. Bicarbonate, it is acidosis should be optimized, which again leads to better circulation. BUN should be less than 70, creatinine should be less than 7, preferably less than 5, because the studies had shown beyond this level, the uremic bleed risks are more. Similarly, BP optimization and hemoglobin more than 10, because of course surgical, the risk of bleeding is there, so we need the hemoglobin optimized. If the patient is on hemodialysis, dialyze well a day before surgery or on the day of surgery. Avoid anticoagulation in the dialysis, ultrafiltration to the dry bag to keep the patient euvolemic, and post dialysis after 4 or 8 hours to recheck the electrolytes and coagulation parameters. If patient is CKD and not on dialysis, then dialysis may not be required if patient is euvolemic, doesn't have any uremic symptoms, or is hemodynamically stable. Potassium is less than 5, sodium is more than 130, and creatinine is less than 7. In this state, patient may not require dialysis, but if any of these are not as per the requirement, then patient may have to be dialyzed to optimize him before the surgery. Similarly, counseling the patient before surgery will be very important to counsel the relatives regarding the risk of AKI. For that, various tools are available for risk stratification. Various scores have been developed, which take into consideration the kidney parameters, the creatinine, eGFR, and also the non-kidney parameters like the associated comorbidities, patient is failure. So there are various scores like Cleveland Clinic score, Society of Thoracic Surgery score, then new score by MAKE, that is major adverse kidney events. So, but these require further validation in Indian population. Then preoperative drugs. So these are very important list, like whether patient is on ACE, ARBs, like olmesartan, telmisartan, this need to be stopped because they alter the hemodynamics and impair the renal autoregulation. So at least 48 to 72 hours, these drugs need to be stopped. SGLT2 inhibitors, similar way, they even affect the hemodynamics, and also they may lead to euglycemic ketosis post-operatively. Hence, they need to be stopped 72 hours before the surgery. Diuretics, depending on the volume status, if patient is hypovolemic, stop the diuretics. Patient is hypervolemic, we need to step up the diuretics. Beta blockers and clonidine needs to be continued pre-op. Even if you see the anesthetic chart, they will ask to give the beta blockers and clonidine, because if we don't give, they may cause rebound hypertension. Antiplatelets as per surgeon and cardiologist's advice. And it is very important for CKD patients or CKD not on dialysis patient to preserve the left hand and avoid pricks, because especially the cephalic vein has to not to be cannulated, because in the future, this hand, these veins are used to prepare AV fistula, which is the lifeline of these patients. Hence, it is very important to preserve the left hand or the non-dominant hand. Uremic bleeds are common because of the platelet dysfunctions. So how can we prevent them? So dialyze, if patient is on dialysis, dialyze well before the surgery, optimize well, raise the hemoglobin, hematocrit, and EPO. So in the physiology, we see that the flow of the blood, usually the RBCs are in the center and there is a platelets are in the periphery. There's a laminar flow. So when there is anemia, this laminar flow is disturbed, and therefore platelet function and response to bleeding time is again impaired. Hence, it is important to raise the hematocrit and hemoglobin before. Desmopressin can be used as a rescue, preoperatively giving IV or intranasal. This will enhance the platelet function and definitely decrease the bleeding. Only thing we have to remember here that preoperatively patient sodium should be optimized. If the sodium is low, below 135, 130, we should avoid it because it can precipitate the hyponatremia. And of course, we need to have a platelet and FFP standby if there is a major bleeds. Intraoperatively, protect the vascular access. If patient has a AV fistula, avoid pricks, avoid blood pressure, taking blood pressure on that hand, and preserve the fistula. Police catheterization as per the native output. If patient is chronic kidney disease on maintenance hemodialysis, not having any native urine output, avoid catheterization, maintain hemodynamics, maintain mean arterial pressure above 70. IV fluids, balanced electrolytes is preferred to maintain euvolemia, avoid fluid overload, watch for hyperkalemia, acidosis, and sugar control intraoperatively. Post-operatively, strict intake output charting, daily weight once the patient is mobilized, monitor urine output hourly. So this will help us to guide the fluid therapy, daily renal chemistry and electrolytes. The nutrition, of course, enteral nutrition early starting will be preferred. Drug dose adjustments, adjustment of antibiotics and drug dose, and SGLT2 inhibitors and ARBs which you have stopped are to be started at least after 72 hours after surgery. Then pain management and IV fluid management. So pain management, basically, we have to avoid the non-steroidal anti-inflammatory drugs. Acetaminophen, paracetamol will be preferred, and tramadol. Opioids, short-acting will be preferred and are safe like fentanyl. Avoid long-acting opioids. Fluid management is a challenge to determine the fluid status. Clinically, it can be assessed with edema, Krebs, oxygenation. And on 2D echo, it can be assessed with help of IVC, left ventricular end diastolic pressures, and lung comets. So it is very difficult to assess, and this physical measures are very less sensitive. So it can be seen that lung ultrasound, which had shown moderate to severe congestion, had no Krebs on physical examination 61% and no edema in 80%. So physical examination will have a very low sensitivity. Similarly, our conventional method of X-ray chest and NT-bro PNP versus the lung ultrasound had a lung ultrasound had better sensitivity and specificity and very better turnaround time of determining the fluid status. Similarly, the bioimpedance analysis and the lung ultrasound are much better and easily available and accurate ways to measure the fluid status. So even in non-dialysis patient, this bioimpedance gives a good idea when patient doesn't have Krebs, when patient doesn't have any edema. So patient is euvolemic, give maintenance fluid, normal saline or balanced solution. If patient is hypovolemic, hydrate well with the balanced solution. Avoid large volume salines or hyperchloremic fluids to prevent hyperchloremic acidosis. If patient is hypervolemic, restrict the fluid, add diuretics, because with each kg rise in fluid overload, there is increased mortality in these patients. So key to success is good preparation and multidisciplinary approach. Thank you. So next, we will have Dr. Mukesh Shetty sir presenting on nephrology for the non-nephrologist in his own artistic way.
Basically, I'm going to just present one case, and you'll realize how this case so we are just going to have one case. I have deliberately labeled it as nephrology for non-nephrologists because this is usually a case which is often seen by many. And of course, nephrologists also being part of this management. And this one case passes through a lot of other phases and complications, and how probably it would be the ideal way to treat this. So this is a patient who is probably seen by a physician also, diabetologist also, cardiologist also. He's also been referred to dietitian, and of course, nephrologist is also part of this. And I'm talking about a patient who's a 61-year-old lady with type 2 diabetes for almost 8 years. Patient has been on metformin and glimepiride. and he's come for the first visit to a physician. And they found that, yes, the patient was on irregular therapy, patient was consuming zarda, which is a tobacco-like preparation. And for hypertension, which was established 4 years prior, patient was receiving telmisartan 80 mg. Some trouble in reading, known to have cataract, depressed, forgetful, eats irregularly. So that was the background of a patient. So just to recapitulate, hypertension, diabetes, metformin, glimepiride, and telmisartan. That was the story. On physical examination, height was 162, weight 59, BMI was okay, blood pressure was on the higher side, 156 by 96. Patient had early nuclear cataract, but there was no evidence of diabetic retinopathy. That's an important observation, and I'll correlate why it's important. Lungs were clear, heart sounds normal, abdomen normal, no edema, no neuropathy, no deformity. A simple case of diabetes, hypertension with a slightly higher BP. The sugars were also uncontrolled. Fasting was 142, postprandial was 213, HbA1c was 7.8, an abnormal lipid profile. Triglycerides were high, 250, cholesterol 251, LDL, HDL also being on the abnormal side. Creatinine was absolutely normal, but urine albumin to creatinine ratio was 56 milligram per gram, and that would be considered as microalbuminuria. ECG showed an incomplete RBBB. So here's a patient who is diabetic, hypertensive, has microalbuminuria, creatinine normal, so far receiving glimepiride, metformin, and telmisartan. Anything missing? Do you think this is the appropriate treatment for the patient, or there should have been some alterations? So the points which were probably not controlled well were that the glycemic control wasn't good. All three parameters were high, the fasting, postprandial, as well as the HbA1c. BP was also on the higher side. There was microalbuminuria. Nothing was done for that. Patient continued to eat zarda, no counseling on that. There was irregular eating pattern. Again, that was the obstacle for control of good glycemic control. So there were other issues, and probably all that would act as a risk factor for the cardiac event. And in fact, there is a possibility that such patient will have a renal deterioration. So that's how the prescription needed modification. And then naturally someone thought of altering the drugs. They were thinking about adding gliptin or some more drugs to improve blood pressure, maybe calcium channel blocker or a diuretic. And finally, the prescription given was, that is, oral hypoglycemic drugs were changed to vildagliptin with bendmorphin. Amlodipine was added as an antihypertensive. Telmisartan 80 mg was omitted, but it was converted into telmisartan with hydrochlorothiazide, because probably a diuretic would probably prevent the hypertension by salt loss. For her abnormal lipid profile, rosuvastatin with fenofibrate was given. And with those drugs, they monitored the patient and they found that, yes, sugars are fairly getting controlled, blood pressure is getting controlled, those slightly down. But what was surprising, that the creatinine went up to 1.3, and actually physician could probably think that, yes, if everything is controlled, why creatinine should go up at around 1.3. In fact, the telmisartan dose was reduced from 80 to 40 mg, but yet the creatinine was noted to be on the higher side. So is this the right prescription, or do you think that there should be some modification? And again, on follow-up, they found that, yes, sugars are almost getting controlled. HbA1c is 7.1. In fact, urine albumin to creatinine ratio is also reduced. Weight is controlled. BP came down very well. Cholesterol was 167, came very well. Triglyceride was 124, came very well down. But in fact, creatinine went up from 1.3 to 1.6 milligram per deciliter. So they thought that, yes, it is probably still that residual effect of telmisartan hydrochlorothiazide, and which was omitted. And they're hoping that if everything else is controlled and ARBs are stopped, probably the creatinine would start coming down. But much to their surprise, the creatinine went up to 1.9. And in fact, because hydrochlorothiazide was omitted, the edema fit started appearing. So what is the correlation? Do you think this is worsening of diabetic kidney disease? But in fact, microalbuminuria had dropped down. Is it worsening of hypertensive kidney disease? Probably it's not matching. 4 years of hypertension, first of all, should not give rise to kidney damage. And even hypertension is controlled with amlodipine and other drugs. So is there any drug induced? What was the other drug left out apart from anti-diabetics, which probably could have played a role in increasing the creatinine? But before that, we'll just see that usual very popular labeling to any patient who has creatinine being higher and who is diabetic and hypertensive is either a diabetic kidney disease or a hypertensive renal damage. So first, let's just thrash out our basics on that, that if there is diabetes or hypertension as a risk factor, and if it causes endothelial dysfunction, there will be microalbuminuria. So in fact, microalbuminuria is a surrogate marker of endothelial dysfunction. It would then progress to macroproteinuria and then nephrotic syndrome and maybe end-stage renal disease. So by the time you get creatinine of 1.6 or 1.9, you should have developed overt proteinuria. In fact, in this case, the microalbuminuria was also dropping down. So that's not the renal continuum related to diabetes or hypertension. Then the drug of choice, amlodipine. Do you think this is the best drug? Though it controls BP, when you give amlodipine, it's mainly afferent arteriolar vasodilator, but not the efferent. And that is why you'll find a flood of blood in the intraglomerular apparatus, causing transient increase in the intraglomerular pressure, enough to sometimes liberate proteins, and that itself will not be able to control proteinuria. But if you have an equal afferent or efferent dilator, or an only efferent dilator, like ACE inhibitors, and that is why it was given the status to ACE inhibitors that they are anti-proteinuric, because by dilating efferent arteriole, you're going to drop the intraglomerular pressure. So if at all you choose the right antihypertensive in the setting of diabetes and hypertension, then probably it should be either afferent efferent dilators or efferent dilators, but not only afferent dilator. So amlodipine or hydralazine or those major vasodilators should not have been used, like prazosin, but you could have probably used ACE or cilnidipine or ifenadipine, because these drugs are more preferred in this scenario. Now, if I had to really label it as diabetic kidney disease, what we mentioned is the patient did had cataract, but there was no diabetic retinopathy. And in our setting, diabetic retinopathy play a very major role in order to correlate with diabetic nephropathy, because both of them are similar. We have a membrane, we have a vascular network. If vessels are only undergoing changes because of diabetes, you will get those membrane changes. In the kidney, it will be glomerular damage. In the eyes, it will be the retinal damage. So non-proliferative diabetic retinopathy had 2.9 times, and proliferative diabetic retinopathy had almost 16.6 times higher risk of CKD progression. But in our case, that was not there. So unlikely diabetes playing a role for damage. So often we get a patient who has diabetes, who has kidney disease, but there is no relationship between the two. Rather, there is a term called as non-diabetic renal disease. And there are certain points by which you can differentiate between the two. If it's diabetic nephropathy, you'll have albuminuria, there'll be bland urine sediment, there won't be RBCs or RBC casts, there'll be slow progression. Usually the duration of diabetes is more than 5 years. But if all that is not seen in a given setting, like there is extreme proteinuria, 10 or 15 grams, there is active urinary sediment, microscopic hematuria, the duration of diabetes is less than 5 years, that should actually force you to think about a non-diabetic renal disease, which could have been anything like a stone disease or a glomerulonephritis or any other systemic disorder affecting kidney. So in this case, probably that was not the scenario. And this is the renal continuum of hypertension with kidney damage. We often see a patient who is 27-year-old, hypertension since 4 years, creatinine of 1.8, and being labeled as hypertensive renal disease. In fact, if hypertension is supposed to damage kidney, it would take exactly 20 years to damage. And this is the phases under which there will be changes in the kidney. With high pressure, initially the renovascular resistance will go up. Then there will be some alteration in the renal vasculature. Filtration pressure would drop. Then there will be glomerulosclerosis, and finally end-stage kidney disease. This entire process takes almost 20 years. So if you have the 4 years history of hypertension and elevated creatinine, in fact, it was renal-induced hypertension and not systemic hypertension damaging kidney. So time match is most important. So is it drug-induced? In fact, we forgot in this entire history that patient received one drug for the cholesterol as well as the lipid control, and that was fenofibrate. And in this case, it was in fact fenofibrate elevated creatinine. And the history is more hemodynamic. Fenofibrate often leads to hemodynamic alteration in the kidney. It is not a nephrotoxic drug. It doesn't lead to drop in GFR. It doesn't lead to any structural damage. It just alters the prostaglandin level and results into excessive vasodilatation, drops the intraglomerular pressure, and that is why the creatinine started going up. This also is an initial phenomena. If you still continue this drug over a period of 10 to 12 weeks, you'll find creatinine again getting normalized. And by around almost 20th week or couple of months, you'll find creatinine is back to normal. But in this medium phase, where we start seeing increasing creatinine, we get naturally worried about the individual and start labeling that, oh, probably there's something worsening, and maybe many people will go ahead and stop the fenofibrate. So one can either observe, reduce the dose, or even continue. And now there are papers coming up where fenofibrate is supposed to be nephroprotective. It in fact acts on the cellular pathway by which it can prevent the damage to the renal vasculature, renal glomeruli, renal tubules, and interstitium. And it is probably one of now the nephroprotective drug being labeled. And that is why it's our choice whether we want to continue, observe this phase of increasing creatinine, explain the individual that it's not something doing very harm to your kidney, but it's a transient phase. The next scene is 6 years later, this patient becomes 67-year-old, but starts getting stabbing pain in the epigastric region. The BP is still on the higher side. We could not, in fact, achieve the target blood pressure. There was no edema now. Heart, lungs were normal. Sugars were slightly on the higher side. HbA1c started going up, but creatinine further went up. Now that means even after the fenofibrate elimination, the creatinine did not come down. So probably, and again, the patient had lost to follow-up. So even in between, if creatinine is normalized, there was again a rise in the creatinine. And again, we are forced to think about some new causes in the patient. The USER was 178 milligram. Microalbuminuria also worsened. ECG was the same. Echocardiography showed LV ejection fraction of 61%. So this epigastric pain with exertional dyspnea NYHA2 naturally forces us to think about a cardiac involvement, and probably that is the reason. So naturally one would think that yes, this is the time where we should do a contrast study, coronary angiography, but the problem is creatinine. It's 2.83 milligram per deciliter. Question is to be or not to be, and that is the question. And now many of them would worry that no, if I now do subject this patient for contrast study, probably may land up with dialysis. And there's a big fear amongst the cardiologists as well as amongst the nephrologists whether such patients should be subjected. And if you do not subject, naturally your story remains untold, because the coronary angiography, if not done, you're going to miss ischemic heart disease. You may gather any indirect evidences on stress echo or dobutamine echo, but if you do not get the right knowledge about coronary blockage, the ischemic cardiomyopathy would worsen. And for that, no, the problem is the cardiologist say, जाओ पहले उस नेफ्रो का साइन लेके आओ जिसने तुम्हें एंजियो के लिए फिट किया है. Okay, nephrologist will be confused further, and of course patient is highly confused because it's not clear that a cardiologist is right or a nephrologist is right. So a little data on that if you think about various the contrast agents being available, they are broadly classified as ionic and non-ionic. Ionic are the one which are basically having 3 iodine atoms as well as the carboxyl group, and they will dissociate into cation and anion, and that's why the osmolality is often high. But if you have non-ionic, then probably the osmolality is low. In fact, now there are iso osmolar also concentrations available like Visipac, which has the least osmolality, which is 290, and these are very safe. And that is why, and you have to also identify that which patients are likely to get acute kidney injury after contrast. Not everyone would get acute kidney damage because of contrast. There are some of the risk factors like either a known case of CKD or a diabetes mellitus, or there's a very bad heart, age, female sex would be more prone, someone who is already critical, anemic, hypotensive, already on some coexisting other nephrotoxic drugs, especially which are oncology related, hypercholesterolemia. These are some of the clear settings. In normal population, the contrast-induced nephropathy is only 2%. And when there are risk factors, it zooms up to around 25 to 30%. So it's not a huge burden. And if you choose the right osmolar concentration, probably you'll get away. So the method by which iodinated contrast damages is basically by tubular as well as vasoconstriction, as well as oxidative stress. And there are methods to prevent those. A good hydration, a good alkalinization, N-acetylcysteine, which is a glutathione donor, and that causes the minimization of oxidative stress, and the remote ischemic reconditioning. Statins sometimes, all of them are now known to prevent the contrast-induced nephropathy. In fact, there are papers and papers coming that this is a single center study that they have been doing the contrast study even with a creatinine of 2.5 to 5, and they use only 10 to 15 cc of contrast, which is Visipac, and they have not reported a single case of contrast-induced nephropathy, even in the patient with high creatinine. So we are not talking about the other risk factors. Known CKD also, they could get away without any contrast-induced nephropathy. So it's more hyped entity than the actual, and that's how, if patient needs study, despite limitations of CKD or creatinine, one should subject, because heart will always prevail over kidney. If heart stops, naturally nothing can be done. If kidney stops, at least we have dialysis. So with this view in mind, contrast-induced nephropathy should never be deferred if it's really indicated. Now the final ad, but somehow this patient could not be subjected to, because the patient in that confusion did not bother to follow up. Almost many years passed. Now the dyspnea has worsened. It is NYHA 3. Already there are other features like pallor, BP is in fact stabilized, pulse is high, edema is coming up, the crackles are coming up, there is now fluid overload, hepatomegaly, minimal ascites. So this patient has certainly worsened because the ischemic cardiomyopathy must have taken a toll. And now when they were subjected to further studies, they found that the creatinine is further gone up to 3.9. Her LV ejection fraction is reduced to 31%. There is global hypokinesia, microcytic anemia, and all other CKD markers like low calcium, low vitamin D, high PTH, everything is coming up. Congestive hepatitis with SGOT, SGPT elevated. So now patient is almost having an established cardiorenal failure. So the trouble is, what next in such cases? So this patient initially had the heart failure with reserved ejection fraction or a normal preserved ejection fraction, and then patient progressed to the reduced ejection fraction. In fact, both of these elements would worsen the renal function. When you have preserved ejection fraction, because of the back pressure event, venous congestion, hypertension, diabetes as other cofactors, inflammation, oxidative stress, you get renal fibrosis. And naturally, when reduced ejection fraction, your forward flow will be reduced. So with preserved backward flow and with the reduced forward flow, both would damage the kidney. And that's why there will be rapid worsening of kidney function. So in our patient, if you see the entire trajectory, patient are now established into cardiorenal failure. And with preserved ejection fraction, the drugs which are often given to them are SGLT2 inhibitors, loop diuretics, MRA, which are coming up, ERNI, and even ARBs. And these are the various drugs which will probably use to maintain the heart failure. So now, to sum it up, what must be the actual cause of renal dysfunction in this patient? Do you now still feel it is diabetic nephropathy? Of course not. As we said, that patient was never over proteinuric. Is it a non-diabetic renal disease? But at least the other causes like glomerulonephritis, stone, infection, obstruction were not there. Hypertensive nephrosclerosis, even the time scale is not at all matching. Patient develop all this too fast, and if it is hypertension related, it should have taken at least 2 decades. So whether it is secondary cardiorenal syndrome, and now we are clear that the entire travel of this patient from normal renal function to abnormal renal function was actually due to cardiorenal syndrome, because unfortunately patient after renal damage started having coexisting cardiac damage, which remained unanswered because contrast could not have been done, and no aggressive management done at the cardiorenal failure, no prescription like ERNI she ever received, mainly because she lost to follow-up, and all that have ultimately resulted into worsening of the renal function secondary to cardiac damage. So actually, it was a type 2 cardiorenal syndrome where you have chronic cardiac related chronic renal damage. Of course, now all these drugs have been added, vildagliptin, metformin continued, low dose of telmisartan added, mainly in view of the cardiac failure. ERNI was also added, diabetes, hypertension, heart failure was controlled, anemia was controlled, diet and salt, the other nephrotoxins were altered. And finally, whenever it comes to diet, patient is always inquisitive that no, I will finally know what exactly now, enough is enough, I don't want to further deteriorate, let me now know the proper diet. The SGLT2 inhibitor, everyone knows that in the initial phase, when there is hyperfiltration injury, that is prevented by SGLT2 inhibition, because that will deliver more sodium to the distal tubule, and by the tubular feedback mechanism, the afferent dilatation would stop, afferent constriction would occur, hyperfiltration would stop. So in fact, this drug should have been given way back very early when patient was almost labeled as diabetic hypertensive with normal creatinine, because that's the only drug which is going to prevent the progression of renal damage. And once the microalbuminuria starts, creatinine goes up, you only have forward generally and nothing to actually come back. And that's why SGLT2 inhibitor is now given undue importance. Even DAPA CKD trial has confirmed its role into the renal preventive damage. So now diet is the final thing. The usual diet is low sodium, then avoid canned packaged foods. We already saw the importance of low sodium, limit potassium, lowering protein intake, limit fluids. Now, the problem of low protein diet is everyone would, even dietitian would naturally aggressively say that you have to be on LPD or VLPD, that is low protein diet or very low protein diet. And the benefits are, if you're on low protein diet, the glomerular hyperfiltration stops, proteinuria minimizes, uremic toxins, which are actually byproducts of protein come down, oxidative stress may come down, phosphorus level will come down. So all over better uremic control. But the drawback is when you are already consuming less protein, there is a huge problem of protein energy wasting. Our patients are already pro-inflammatory, catabolic. Now this hypercatabolism will go up. There is nothing to have an anabolic effect. Slowly they'll get wasted. So the idea is before prescribing a blanket LPD or VLPD, just actually see the ethnicity, racism, the dietary recall, and see whether the patient is really on high protein diet. This concept of protein restriction is mainly Western, because if the morning if they use bacon, then they use lamb, then they use pork, the animal changes, that the protein intake continues. And their protein intake could be even 1.5 gram. Our people who are the best non-vegetarians would not eat on Monday, would not eat on Thursday because it is Datta Chavar, it is this war, that war. The overall protein intake, even in the best non-vegetarian people, is not more than, say, 0.6 or maybe 0.8. The entire Indian country is basically malnourished, and the average protein intake is way below. In fact, there was a study done by the WHO and in India, and they found out that 87% Indians are taking proteins less than normal. So where is the question of protein restriction? In fact, these patients who are initially diagnosed as CKD, they are like muscular, they are like well-built. And when they travel through all this journey, various other advices, and then everyone is, even in the family, say that no, protein you should not eat because it will convert it to creatinine, and that huge protein restriction will convert them into completely malnourished. And by the time they go for dialysis, they are not even fit to undergo for dialysis. So that's the message, that what we normally do in this journey and what could have been modified for the best control. That was the whole purpose of taking this case forward. Of course, kidney health for all, advancing equitable access to care and optimal medication practice. Thank you.
So as the name suggests, I am going to talk on atypical mycobacteria. And I'll emphasize more on microbiological diagnosis because it is the confirmatory diagnosis for atypical mycobacteria. So I'll start with first case. This is a 65-year-old male. He had history of CABG 1 month back. It was done outside. And he presented to us with pus discharge from sternal wound since 5 to 6 days. He had history of diabetes. On examination, pus pockets were seen in the sternal region. So patient was taken for wound debridement and vac dressing under cover of antibiotics, and samples were sent for bacterial culture. So gram stain did not show any organism. Bacterial cultures were negative at 48 hours. But as per our policy, we incubate all our tissue samples, pus and fluids for at least 5 days. So at day 5, there was a growth of atypical mycobacteria on the routine culture plate, blood agar plate. So on doing AFB smear, it was AFB positive. Later on, we identified it as Mycobacterium fortuitum with the help of Malditov. So drug susceptibility test was done with the help of microbroad dilution test, which is the gold standard for sensitivity of NTMs. And the treatment was started in form of levofloxacin, amikacin, and linezolid. Amikacin was given for first 2 weeks, and later on, based on the antibiogram, the treatment was tailored to clarithromycin and minocycline. So after 15 days, the patient was taken for secondary suturing. So you can see the first picture, that is just after VAC application and before closure. Then secondary suturing was done. The wound healed well, and the patient antibiotics were continued for 9 months. So you can see the second picture of healed wound. Then coming to my second case, this is a 30-year-old female. He presented to our surgical OPD. She had history of LSCS done 7 months back, and she came with non-healing wound at LSCS site and discharge. Wound swab was collected and sent for culture. So again, on gram stain, there were no organisms seen and cultures were negative. On MRI, serpiginous sinus tract involving lower rectus and extending to preperitoneal space with small encysted collection was observed. Her WBC count was 4,600. So she was taken for sinus tract excision, and this is the intra-op image, wherein deep extension of the LSCS scar up to peritoneum is observed. So the entire sinus tract was removed and samples were sent for AFB smear, culture, gene expert, and histopathology. Again, her AFB smear was negative, gene export was negative, bacterial culture was negative. But on extended incubation and on TB culture, we grew atypical mycobacteria, which was identified as Mycobacterium fortuitum. And the patient was started on clarithromycin, linezolid, and amikacin. The treatment was continued for 4 months, and the wound healed properly. Then this is the third case. 24-year-old male was operated for right ACL tear repair outside, and he also underwent debridement outside. So when he came to us, he had mild swelling, pain, discharge at the operative site. MRI showed signs of infection. WBC was 8,700 and CRP was 34. So he was taken up for debridement, and the samples which were sent showed AFB smear positive and gene export was negative. So we thought it is an NTM. Therefore, we did NTM PCR, which came out to be negative. Later on culture, we grew Mycobacterium abscesses, and his histopathology also showed granulomatous inflammation. So there's one more case. Okay, this is a pacemaker site infection, which also grew rapid grower, which required explantation with lead extraction and a prolonged course of antibiotics. So what are atypical mycobacteria? These are mycobacteria other than tuberculosis and leprae. They are also called as NTM, non-tuberculous mycobacteria. So they have emerged as an important opportunistic pathogens in recent years. They are ubiquitous in environment and found in indoor and outdoor water sources, soil, etc. More than 150 species have been identified. The most common presentation is pulmonary disease, followed by extrapulmonary infections. So pulmonary disease is present mainly in patients with pre-existing disease like bronchiectasis and cystic fibrosis. Extrapulmonary infection can present like skin and soft tissue infections, bone and joint infections, lymphadenitis. These are more common in immunocompromised patients, in young children mainly lymphadenitis, individuals with indwelling medical equipments, surgical and non-surgical procedures. So based on the rate of growth, they are classified as slow growing and rapidly growing. So rapidly growing are those which grow within 7 days of incubation, and slow growing are more than 7 days, but they usually grow after 14 days of incubation. So among slow growing, Mycobacterium avium and intracellular layer and Mycobacterium kansas are the main organisms which are important and cause clinical disease. And amongst rapidly growing mycobacteria, Mycobacterium abscesses, fortuitum, chinoli are the main organisms which cause infections. So why are we concerned about rapidly growing mycobacteria? They are known to cause outbreaks, specifically skin and soft tissue infections after invasive procedures, injection abscesses, and infections following cosmetic surgeries. They are known to be drug resistant. They are resistant to routinely used disinfectants, low-level disinfectants, and anti-TB drugs don't act on rapidly growing mycobacteria. So these are the common ones. So Mycobacterium fortuitum and abscesses, they can infect healthy individuals, but Mycobacterium chilone, it usually infects immunocompromised patients. So now when to suspect NTM infection in a post-operative patient? So these patients usually they have very uneventful post-operative period, but they present maybe after 15 days or 1 month following surgery, and wherein the scar breakdowns and there is persistent non-healing superficial wound. Sometimes they progress to discharging sinuses. Cultures are generally sterile and they don't respond to routinely used antibiotics. Okay, usually there are no systemic illness. And if at all AFB smear is positive, gene export is negative. So these are some hints wherein we can identify that this could be NTM infection. So then coming to lab diagnosis of NTM, first and foremost is AFB smear. The sensitivity is around 30 to 60%. Though the morphology of NTM is slightly different than that of MTB, it is very difficult to comment on AFB smear. Second and important one is culture. So mycobacterial culture, the sensitivity is 65 to 70%. It grows well in solid as well as liquid medium. It also, rapid growers also grow properly on routine bacterial cultures like blood agar and chocolate agar, or even McConkey agar. So only thing is that it has to be incubated for a longer period. So important thing is the lab has to be informed about the detailed clinical presentation. Then the lab will put necessary media plates for prolonged incubation. Histopathology will also show granulomatous inflammation. Gene expert is mainly not to identify NTM, it is mainly to rule out MTB. NTM PCR is available, it is very sensitive. Identify which type of rapid grower is there in the susceptibility profile or sensitivity profile of different rapid growers is different. Mycobacterium abscessus is very resistant. Whereas Mycobacterium fortuitum, there are many oral antibiotics which are available against Mycobacterium fortuitum. So identification is important. The basic identification to differentiate between MTB and MOTT or NTM is the MPT64 antigen. So this is an antigen which is secreted by MTB. And it is positive in MTB, negative in NTM infections. Then MALDI-TOF and LPA, that is line probe assay tests, are available. The results are usually obtained within 2 days. And they are very quick. So we get rapid results. Then what can we do to improve isolation of rapid growers? We have seen many cases wherein, specifically from outside, wherein we get samples which have been already processed in some other labs. But because the proper history was not given to that lab, the cultures were discarded within 48 hours. So giving appropriate history is very important. Secondly, sampling. Swabs are not usually recommended for mycobacterial cultures because they very limited culture material is available, so the sensitivity drastically reduces. Therefore, aspirated pus tissue samples are ideal. And as I have mentioned earlier, bacterial culture should be incubated for a longer period in such type of cases. Then susceptibility of RGM. It is also very important to do susceptibility of each and every isolate because there is something called as inducible microlead resistance. So now we know that most of the treatment or regimens used for treating atypical mycobacteria is based on clarithromycin. But there is something called as inducible macrolide resistance, wherein clarithromycin resistance is seen in Mycobacterium abscessus. So what happens is that at day 3 of the test, the antibiotic will seem to be sensitive, but prolonged incubation of 14 days has to be done to identify appropriate resistance. So doing sensitivity test is equally important. So these are the empirical antibiotics which usually work very well in rapid growers: amikacin, imipenem, and clarithromycin. So these can be started while awaiting susceptibility test, and the duration depends on the severity of infection. So 2 to 12 months is the routine duration. Then coming to most important, prevention of NTM infection. So proper sterilization of instruments is very important. First and important step of sterilization is mechanical cleaning. So dismantling of instruments, cleaning with enzymatic cleaner, using ultrasonic technology to clean and remove the organic matter is very important because disinfectants will not act in presence of organic matter. So this is the first very important step. Second is water that is used should be clean or sterile. Or RO water should be used. If tap water is used, again, we are going to recontaminate the sterilized equipment. So take-home message is non-healing post-operative wound infections that do not respond to antibiotics used for pyogenic infections and having sterile routine aerobic cultures should raise a suspicion of NTM. Appropriate sample collection and processing is important to confirm the diagnosis. When established, infection should be treated aggressively with adequate surgical debridement and long-term antibiotics. And prevention of such infections is of utmost importance. Therefore, appropriate sterilization of instruments and adherence to infection control practices is very important. Thank you. Dr. Sukhi. Yes. So that is the most important thing. Yeah, because it is very difficult to transfer that material to a culture plate. So if at all swabs are used, it has to be properly immersed and it has to be saturated with the sample. Then only swabs can be used. Otherwise, we need tissues or aspirates. No. Yes. Yes, normally.
What about the slow growers?
They will grow on TB culture medium. They will not grow on routine plates. But these ones, the rapid growers, we usually isolate from our routine culture medium. And we have made a rule that all such growths, we do AFB culture and gram stain both, AFB smear and gram stain both. Otherwise, many times these are missed because they look like contaminants. They look like normal diphtheroids or the corynebacteriums which are there on skin. So doing AFB smear is very important on such cultures.
See, at least 2 patients of
Yes. Yes. Yeah, recently we have seen many cases. So I thought it is very important to discuss this.
Like the open instrumental laparoscopic instrument with Sidex or Parasite, they don't kill the mycobacterium spores. But luckily we do, if you are doing this either ETO or proper heat sterilization. autoclaving-
Yeah, but for LSCS, all the instruments are autoclaved,
No,
right? But still we see.
So
basically-
very we have seen is a forceps, scissors, and the small instruments. Now, some of the instruments they just do it side.
In a year, at
Because
least
it's a reptile
one at
movement,
least we do not debridement in a year.
center.
We see from outside also.
They don't know.
So these patients, most of them received on OPD. We have received samples on OPD basis.
And
Plasma
we-
sterilization.
We
Plasma
So,
sterilization.
outside what-
We had a
reptile,
meeting.
See, if each and every step is meticulously followed and the disinfectant, high level disinfectant that is used, if the efficacy of that disinfectant has to be tested daily. If that is not done and that is missed, and the water that is used for final rinse, if that is sterile, all these things matter.
Thank you, Kashmira. Today, actually, Dr. Ashish reminded me that actually we all remember, sir. Dr. Gautam Ramakanthan, we'll just give 1 minute remembrance to him, those who don't know him. Dr. Gautam Ramakanthan was a chief gastroenterologist over here at Jupiter and the director. He passed away, left his mortal body 5 years ago on 24th February. And we all fondly remember him. He was a thorough gentleman and a thorough academician. He was very happy to attend grand rounds and participate in any thing. And coincidentally, Dr. Hasse's room is, sir's room is taken over by Dr. Hasse. And today Dr. Hasse had a talk. So we all were remembering Gautam sir. And just a brief this thing of remembrance to him. Those who are on Zoom, for them to know that Dr. Gautam Ramakanthan was the main person who had helped us to start the grand rounds and have it in a continuity fashion. Due to some disease, he left his body in an untimely manner. At a young age of, I think, 62, sir left his body. And he was a main gastroenterologist over here. So Ashish had told me to give a remembrance of him today, so that wherever he is, his soul remains